We wanted to include just a little bit of a lecture and discussion regarding dry needling. Now, dry needling is a little newer to the physical therapy world, and there really isn't a ton of research on it yet, and a lot of it that's being used is acupuncture based, which has a place for sure, but it is not, uh, it by itself is not representative of what dry needling may be able to offer to the physical therapy world. So, what is the philosophy of dry needling as a treatment? There are several different ones. So, I think the most common one that's known is trigger point referral patterns by Travell and Simmons. We'll show some pictures of those as part of our lecture. Each muscle is believed to have some sort of common referral pattern that may present as pain or a headache or something like that. And some believe that with dry needling, you should try and release the tension in that area by using a needle to sometimes recreate and then release the pain that matches that pattern. Another theory for use with it is mobility restrictions. So, hypothetically, if your hip flexor was restricting hip extension motion, needles to the hip flexors may improve the hip flexor length and therefore improve hip extension mobility. May impact neural tension. You can do that by placing needles in the muscles along the path of the nerve, possibly into the nerve, maybe at the spinal segments related to the nerve, really in the muscles that the nerve innervates. Myotomal and dermatomal involvement. So, for example, if a patient presents with L5 myotomal weakness, maybe we want to introduce needles to the L5 multifidi or rector spinae type muscles. And there might be more methods out there as far as why you might perform dry needling. These are just a few examples, and there are various techniques as well, whether it includes electric stimulation, whether it is more of like a peppering or oscillatory type motion, or if it's left in for a sustained period of time. This is not a lecture about how to do dry needling or why, but more so like how it may play a role in the cervical spine. So one of the first muscles we'll go over here is the upper trapezius, and so the Travell and Simmons the referral patterns here can show posterior occipital pain, some pain around the upper trapezius, or medial to the scapular, almost like a Cloward's area representation. You may get on the outside of the head, behind the eye, lateral neck, lateral jaw. So if you see pain in these areas, upper trap needling might be beneficial. You can also consider it for any restricted cervical mobility, headaches, temporomandibular dysfunction. The sternocleidomastoid has a referral pattern in the suboccipital region, behind the eye, the temporal region, and the lateral and upper shoulder as well, which we did not depict here, but if you think about the insertion of the upper trap, or the sternocleidomastoid, it could play a role for sure. Another indication here is if someone has anything painful with like swallowing or around their neck or throat, it's possible that they'll have some relief with it. Obviously, do your normal non-musculoskeletal screening, but I myself have had that happen actually, where I had pain with swallowing and then one needle to the sternocleidomastoid and it recreated my exact pain, and then the needle came out, no pain at all. Indications, obviously matching referral pattern, any restricted mobility, headache, TMD, and like I said, difficult and painful swallowing. Your levator scapula here could have referred pain along the medial scapular border, the posterior scapula, and the lateral neck. Indications are matches the referral pattern, restricted mobility, headache, and temporomandibular dysfunction. Now your cervical multifidi, the indications, obviously, if it matches the referral pattern, restricted mobility, headache, like all of the others, but also cervical radiculopathy. So if a patient presents with C6 cervical radiculopathy, I would probably recommend dry needling C6 multifidi. Referral pattern is typically the posterior cervical spine and upper thoracic region, again matching kind of with that Cloward's area. Next up, we have the erector spinae here. Referral pattern is the posterior occiput, a band around the head, and the top of the head. Indications would be matches the referral pattern, restricted upper cervical mobility, headaches, and temporomandibular dysfunction. Lastly, here we have TMJ musculature. So the top picture here is for the masseter. And so with the masseter, we can have a referral pattern kind of above the eye, around the ear, and around where the masseter lies. And that line there actually is because the masseter and the masseter can refer to teeth, believe it or not. So there are people out there that they may present with a toothache to a dentist, have the tooth extracted, and guess what? The pain was coming from the muscle instead, and that tooth that was pulled out is still hurting. The bottom right picture here is for your medial and lateral pterygoids. So typically you're getting pain kind of maybe behind the eye, maybe a little in front of the actual temporomandibular joint. And then you can get it around the ear as well. And the bottom left picture here is more so for the temporalis. So this is that pain on the temporal region. This also can present as pain as part of your teeth. So anytime you have a patient that complains of tooth pain, this is something that may be related, and the patient might not report it because you're not a dentist, and they're not seeing a dentist at that time. So it might be worth asking if patients come in with headaches, if they have any tooth pain as well. So indications are, obviously, if it matches referral pattern, restricted mobility, headache, and temporomandibular dysfunction. A lot of patients with headaches have a combined components of the temporomandibular musculature and the cervical musculature. The reason being is that they share the same pain center and pain pathway of I think it goes down to C3. And so anything upper cervical spine and temporomandibular muscles should be considered for sure with headaches. Now, again, why we might incorporate needling, I'd say it's another method that we can change our patient's sensitivity. It's another method we can change our patient's mobility. If there's a case where the pain matches a specific referral pattern, to me, that's a no-brainer as long as the patient is open to it, because a lot of times that you can get a significant change in their pain state by incorporating the needles. Now, this is not going to fix everyone. I tell all of my patients there's no treatment out there that fixes everything, but everything out there can help someone. And I think it's our job to try and start screening for people as to what intervention is going to be most effective. Will it be cognitive behavioral therapy? Will it be exercise? Will it be joint manipulation? Whatever. But dry needling has a place that it can be beneficial. And if you're interested and want to learn more, I suggest taking a dry needling course or two so that you can start implementing it and kind of finding your own pathways.